We have a couple of carloads of people who've come up from Regina. You can see there's some biographies that are included in your package. And we're really looking forward to hearing what they have to say. I'm not going to do too much of an intro, so I'll invite our presenters to come up to the table here. So first of all, we have Margaret Baker, who is a member of our leadership team. You've heard her referred to as the policy lead on the tripartite, and she's been the person who's been leading in the coordination of the government presentation. So I'll hand it over to her.
Good morning, everybody. I'm not sure that I'm doing a great job. We have, as I'm the first of several presenters this morning. And I'm really glad that our last presenter just walked in the door. I was getting a little nervous that I was going to have to carry his piece too. So, and I am getting feedback. Are you getting feedback? Am I too close to this mic? And I'm waiting for my presentation to be loaded. Okay. While we're waiting for that to happen, there's a couple slides that I'm just going to zip through because I'm obliged to let you know that or disclose a potential conflict of interest. The Minister of Health is partnering with the Patient Care Industry Collaborative, which is PIHCI, the Canadian Diabetes Association, Saskatchewan Medical Association, and the Saskatchewan College of Pharmacists and Pharmacy Association, to develop a pharmacy-based pilot project focused on improving access and outcome for Saskatchewan residents living with diabetes. And I'm going to get you to the right slide here. So members of the PIHCI, you'll see on the bottom of the slide here, and two of us presenting today, Ramona Furcart and myself, sit on the advisory committee for this project, and I can assure you that we have received no compensation, nor will we be making any therapeutic recommendations. I'd just like to spend a moment talking about primary health care. We have a bit of an identity crisis. Lots of people ask us what primary health care is. It's big and it's nebulous, and people have a hard time getting their heads around it. So I would say that it's the everyday care needed to protect, maintain, or restore our health, and it's often the person's first point of contact with the healthcare system. It's where most people should be getting their non-specialty care, including all aspects of prevention, plus early identification and effective care. And at its best, primary health care is delivered by a team of health professionals who are working to their full scope of practice and providing a home base for healthcare services that meet the needs of the individuals, the communities, and families. So, I know this is a bit of a hokey slide, but I think it illustrates that primary health care is the foundation for the entire health system. And if we don't get primary health care right, if we don't have a strong, sustainable primary health care, then we negatively impact the rest of the health system. Now, all of the work that you're going to hear about from myself and my colleagues are around the 4 betters shown here: better better care, better teams, better value, and better health. And this framework gives us a common vision and helps us move outside of our silos and start to think and act as one, a system rather than individual parts. So operationally, we've translated that vision into outcomes and targets for each one of the priority areas. For primary health care, you'll see our outcome and targets. Our outcome speaks directly to better care. By 2017, people living with chronic conditions will experience better health, and that's as indicated by a decrease in hospitalization related to 6 common conditions that are listed here. These are all ambulatory care sensitive conditions that if we provide better care in the community, it'll have a significant impact on their need for acute care. 2 targets. The first is related to better teams. By 2017, we'll have a 50% improvement of patients who say they can access their primary health care team on their day of choice. And the second target is around better care. By 2020, 80% of patients who are living with one of those 6 chronic conditions are receiving care that is consistent with best practices. So in addition to the outcome and targets that are outlined in the health system for us, our work and policy development in primary health care is guided by the our framework, which is relatively new, released in 2012. Patient-centered, community-designed, team-delivered, a framework for achieving a high-performing primary healthcare system. The name pretty much says it all. The vision and aims you'll see there align very directly with that of the healthcare system. So this was a really broad, this framework represents a broad, really broad consultation and lots of voices. There were some key recommendations. Everyone should have access to a team, and that team should include a family physician, as well as every member of the team should help the patient navigate the system. Services should be designed with and for communities and patients to meet their needs. We heard a little bit about that this morning. They need to be culturally responsive, and we need a workforce that reflects the patients. We heard a lot about the need for flexibility. We need flexibility in service design model and team composition to meet the needs of the community and to build on the assets and the resources that are already there. And again, we heard strongly that we need to think as a system. We need to look at independent family practices and regional health resources and the First Nation system so that we're all working together. One of the first pieces of work following the release of the framework was the development of a primary health care model line, and I'm sure this doesn't show up very well, and you can't probably see the individual components, but what we were trying to do is describing the key components that should be part of the client's primary health care experience. Lots of these were new components that we needed to develop and test, and we're still doing that. For example, shared medical visits, integration with mental health and addiction mental health screening, and components to support chronic disease management, for example, the CDM-QIP, which I'll mention briefly in a little bit. We also developed a maturity model which includes tools and supports to help primary healthcare teams move from the planning stage, which includes community and provider engagement and needs assessment, to a fully functional team that includes all those components that were in the model line, and also builds in quality improvement into the service delivery, which would be our phase 3. So some of our key initiatives, as I've mentioned, much of the work that we've done to date is focused on developing and testing new models of care or components of care, focused on improving access to team-based care and increased coordination and continuity of care. I'll just talk about some of them now. There are lots more, but limited time. So extended hours access, all regions are using lean tools, value stream mapping, PQA data to determine how best to meet the community's needs. Lots of our teams now are offering extended hours access, and they've done that not by adding new resources for the most part. They've looked at when their community members are needing to access services, and they've looked at rescheduling their current resources to be able to meet those needs. Collaborative Emergency Centres, or CECs, we've borrowed this model from Nova Scotia. The goal of this model is to improve patient access to healthcare services in rural and remote communities. CECs are designed to provide care 24/7 to help stabilize and improve access to both primary healthcare and to emergency services. During the day, the public has access to a primary healthcare team that will include a physician and nurse practitioner and others, with extended hours into the evening on the weekends. And the overnight care, though, is handled by a registered nurse and a paramedic with physician oversight via phone. We've implemented 3 CECs to date: Maidstone, Shaunavon, and Kenora. There's 2 more in development. These are communities that had frequent service disruptions. They were really having a hard time to provide service on a consistent and predictable manner, and since implementation of the CECs, there have been no service disruptions. So the opportunity, I think, around CECs, well, we need to evaluate. This model is based on Nova Scotia. We picked it up and implemented in 3 sites. We need to determine whether we need to make some changes to reflect the Saskatchewan environment. And we need to evaluate to make sure this is a model. We need to decide if we're going to look at expanding this model, if resources would allow, and if so, where we would do that. New roles for healthcare providers and to support team-based care. CECs, I've already talked about CECs providing a new role for paramedics. There are other pilots in the project that have integrated paramedics into home care and long-term care environments, taking advantage of some of their downtime. We've also introduced RN case managers and primary healthcare counselors to support team-based care. RN case managers provide improved coordination and continuity of care by providing advice and support to patients outside of office visits. The focus has been primarily on supporting chronic disease. Primary healthcare counselors provide mental health and addiction services, such as screening and brief interventions, right in the primary healthcare setting. And in many cases can avoid referral to more costly specialty care. Integrated pharmacy service, I already mentioned in my conflict of interest that we're looking at a project around screening and better management of diabetes. Lots of other opportunities to integrate pharmacists. And they've got an expanded role, for example, they can now do immunizations. So how do we better integrate them and utilize their services? NPs, they're involved in pretty much all of our primary health care clinics. We do have a unique clinic in Moose Jaw that is NP-led and provides urgent care for reducing the needs for people having to seek out care in the ED. So the opportunities, I think, around team-based care, it's really hard to work collaboratively, and if your team members are not co-located, which in reality is, not usually the case, especially if we want to engage new team members. We need to think about how we support them to work collaboratively, to have team members work to their full scope of practice. Challenges are team members often have different compensation medals, and as I mentioned, not co-located. We need to look at incentivizing team-based care rather than individual team members, which is historically what we've done. So complex care, you've already heard Jacqueline talk about the work being done around the data, around identifying folks who we would identify as meeting the needs. We call it, you heard from Corey this morning, connecting to care. So it's a strategic use of data to identify individuals with complex needs and to develop, once you've got that data, to look at how you develop targeted and high-impact ways to be able to meet those needs. The goal is to be able to provide better coordinated, customized care that's more holistic, and so you can meet their needs in the community and keep them out of the acute care system. So we have 2 pilots up and running in Saskatchewan right now, one in Regina that started in January of this year that's focusing on chronic conditions, and one in Saskatoon that started in May of this year that is focused more on mental health and addictions. We have both have about 18 clients each, so the goal is they'll have about 30 by the end of their one-year pilots. And we're seeing most of our data to date from Regina, a really high level of comorbidity, not surprising. Often with underlying mental health and addictions issues, even though the Regina pilot is focused on chronic conditions. And homelessness is a frequent contributing factor. So the teams that are working with these clients are having to reach out to their colleagues in other ministries and their community partners to be able to deal with some of those basic needs before they can address their health care needs. I'll just mention, just on the First Nations piece, that the Saskatoon team has an elder as part of their team, and they are in the process of implementing a sweat lodge. So the challenges here are, you've heard about the data. There's lots of opportunity to use the data to better identify how individuals that we could better serve, and what we can do. We have to identify what the gaps are so that we can build those supports in the community, and looking for indicators that will help us identify folks earlier in their care system or their care journey. So mental health and addictions, you'll hear more about this from Kathy Willerth in just a minute. The Mental Health and Addictions Action Plan was released in December of 2014. The report acknowledges that primary health care providers are often the first point of contact for folks with these issues, and that the healthcare providers are often ill-equipped to deal with them. The recommendation is to provide enhanced support not only for the patients but for the providers as well in the primary healthcare environment. The work that's underway, we're working with our colleagues within the ministry and within regions to do an environmental scan to see what's currently happening. We're planning to increase patient screening and brief interventions, and we're looking at mental health or health promotion around mental health. So technology, I just want to go through this really quickly because there's huge opportunities with respect to with technology on all four of the bedders. EMR implementation key to supporting team-based care, especially if teams are not co-located. We have 85% of family practices that are currently using EMRs, and the focus now, eHealth has just introduced some work to support, just can't think of the name of it right now, I probably have it up there, a maturity model that will help us better optimize the use of the EMR so people are using them to their full functionality. The CDM QIP, Chronic Disease Management Quality Improvement Program, uses technology in the form of electronic smart flow sheets embedded right into the EMRs to support healthcare providers provide care that's consistent with best practices. We're developing dashboard reports that will give a high-level picture of a clinician's entire or a team's entire practice so that they can better monitor their progress. Remote present technology, I don't know how many of you are familiar with that, but it's really cool. Advanced telemedicine technology, high-resolution camera and video, and unlike telehealth, it's not linked to needing a special room. You can connect, the provider can connect anywhere if they've got a laptop and a wireless internet network. Patient portal. eHealth has just recently introduced a pilot around patient portal. This is, I think, a big step forward with self-management, and patients can access their own information. They can actually input information into the portal. I think there's huge opportunities there. And telemonitoring, we need to take advantage of all the opportunities. You heard about cell phones, and there's apps now to be able to monitor your A13 and download it into your EMR. There's telemonitoring. You can connect. You can have your patient weigh themselves on their digital scale, and that can be information can be fed into your team so that they know almost immediately if your patient needs some additional care. So lots of opportunity there. And I just, my second last slide, I just wanted to show you this. This is a primary healthcare logic model, and I know you can't read it. I just wanted you to know that it exists. It talks about all the work that we're doing and how it aligns back to the four bedders and gives you our vision for the future. And if anybody's interested in that, I'm happy to share it. And finally, all four priority areas that you've heard, that you're going to hear about today, have our own objectives and targets, but we have common priorities around access and continuity care and complex care.
Okay, our next two presenters, Ginny Lane and Ramona Furkert, who are going to be speaking us about the seniors portfolio at the Government of Saskatchewan.
Oh, we're not on the right slides yet.
Mental health is on the list.
Good morning, I'm Ginny Lane, and so Ramona and I are working on the Seniors Initiative at the Community Care Branch of Saskatchewan Health. So this is just an introductory slide to show a bit of the context of where we are with seniors' health. You know, on the one hand, we have seniors who are living longer, who have more years of disability, and yet they also have high expectations of care. And you know, this is a change from previous years. We didn't have such high expectations on the healthcare system to deliver to such an extent. And so we do have long-term care, providing residential services, and we have home care providing support in the home. And through those two main things, we are trying to provide the care that seniors do require to help them live at home as long as possible and then to provide care after. And so we do have emerging issues in those areas. Home care is having difficulty delivering on the expectations of seniors, supporting them to age in place in their home. And then when seniors do have to go to different care options, we have a lack of alternative care options besides long-term care facilities. And so some people are not feeling well supported there. And then when they do get to long-term care, sometimes there are concerns of quality, which you have likely heard about in the news over the past year or so. So these are the types of issues that we're currently dealing with. So Ramona is going to talk a bit about the current initiatives that we're currently rolling out in the Ministry of Health, and then we'll follow up with our future priorities.
Okay, so in this fiscal year, we had a new $10 million investment in seniors' care. Included in that is purposeful rounding, which is, the goal of this is to ensure that a caregiver interacts with a resident in a meaningful and purposeful way on a regular basis. The target for this year is to have purposeful rounding implemented in 1/3 of our long-term care facilities, which is 46 in the province. And then the remaining facilities would be implemented in the following two years. For specialized units, there's a small group of individuals from across the province who can't be safely cared for or assimilated into the general long-term care population. So these individuals require a specialized environment to ensure safety for themselves and staff and other residents. So in Regina Capel and the Saskatoon Health regions, we are working to develop a short-term assessment units, which will support the development of a care plan for these residents so that they can be safely and appropriately be cared for. Planning for both of these units continues at the moment with an expectation that they will be operational at the end of this fiscal year. The Regina Capel Geriatric Program. So currently there's only one geriatrician in the entire province who's located in Saskatoon, and the geriatric services that are offered through the Saskatoon Health Region are unable to meet provincial demand. So the geriatric program that's being developed in Regina Capel will focus on seniors who are institutionalized in special care homes, as well as seniors in the community. The region is in the process of recruiting a geriatrician at the moment. For Home First Quick Response, we've heard that seniors want to stay in their homes for as long as possible. So we're trying to support this on a number of fronts, including the new Home First Quick Response program. So we're looking to enhance and improve home care, particularly for intensive short-term needs to sustain seniors to live in their homes for longer. We also want to facilitate appropriate discharge from acute care facilities back to the community and prevent unnecessary admissions to emergency rooms as well as long-term care facilities. And for individualized funding, this is a program that increases choice and flexibility for home care clients. And the additional investment this year has been used to expand the individualized funding program as well as eliminate wait lists in some regions. So we've also made a new investment in the Seniors House Calls Initiative. So we know that people are living longer and sicker in a healthcare system that relies heavily on hospital-based care. Seniors with multiple health issues may experience difficulty accessing office-based health care, which may result in increased or inappropriate use of emergency departments and potential hospitalizations. So Seniors House Calls is attempting to address client and system needs by providing alternate service locations such as home-based care or mobile services. They're also acknowledging the need for additional clinical training in geriatrics. And we're also working to better align programming and linking services and providers. So programming for this initiative began March of this year in Saskatoon and Regina. I believe in Saskatoon they're using a team-based model where physicians, nurse practitioners, and other allied health providers are providing home-based visits and linking with existing programs. In Regina Capel, they're using a slightly different model with nurse practitioners and registered nurses providing services in conjunction with other team members as required. A couple of other initiatives and partnerships to mention. The Ministry of Health does provide funding for the Rural and Remote Memory Clinic at the U of S. So the clinic is addressing the needs of Saskatchewan's aging population by increasing the availability and accessibility of dementia care in rural and remote areas. We also participate in the Provincial and Territorial Healthcare Innovation Working Group called the Seniors Care Theme Subgroup. This group is currently planning a forum entitled Supporting Canadians with Dementia. for October. This is the second event in a three-part forum, which is focused on fostering information sharing and collaboration by sharing research and best practices, showcasing leadership and policy strategies, and discussing innovative approaches to care. And lastly, we also participate in the Federal, Provincial, Territorial Ministers Responsible for Seniors Forum. This is an intergovernmental body established to share information, discuss new and emerging issues related to seniors, and work collaboratively across the provinces on key projects. Areas of focus have included social isolation, aging in place, age-friendly communities, and the role of caregivers.
So just to set the stage where we're going with the future with long-term care, home care, seniors in general, you're probably aware that the Ombudsman recently did an investigation and released this report that basically focused on the quality of care in long-term care. And so the recommendations touched on a variety of organizations, including the actual care home that was involved, the Regional Health Authority, Regina, Capel, and then for the Ministry of Health in terms of provincial recommendations. So the Ministry of Health, we're working quite diligently on our 4 recommendations that we have to address. And so they basically focus on making sure that our provincial policies related to care and special care homes are well written, comprehensive, ensure quality, and that they're actually implemented in the regions and in the care homes, meaning that we have a way of communicating well those policies, making them understood, making sure people are aware of what they're supposed to be doing. And then reporting on those through the development of indicators related to each of our guidelines. And then there was also some specific concerns around the appeals policy and making sure that we do have one that works well and that residents and families can access. And then in terms of longer term, developing some type of a strategy to ensure that the quality in long-term care is maintained and continues for the long term. So then in order to move forward with these things, we have a number of priorities that we've identified for next year for long-term care. We're basically focusing on long-term care during the next fiscal year as we have to put it into manageable chunks to move forward with developing a better strategy for seniors in Saskatchewan. So as I said, in terms of responding to the Ombudsman report, we're really focusing on the quality of care and long-term care in terms of consistent policy implementation, doing some training to make sure staff are able to follow those policies, and then developing a method of public reporting so that families can see that, oh, this care home actually follows this policy and gets good marks on it, and so, you know, it'll be a suitable care environment for my loved one. So the key initiatives will include focusing on some of our indicators. So we do currently have 7 indicators which have been decided upon that we will monitor provincially in all care homes. And we were able to key in on these 7 indicators because we do have the MDS monitoring system implemented in care homes. So this is an assessment system that systematically assesses various care indicators for all residents. And so we have chosen these ones and we've developed targets that basically take into account national level data on these indicators, what our sister provinces are doing around like Alberta, Manitoba, BC, and then where we are in Saskatchewan and where we have to go. And so we're trying to be reasonable, have reasonable expectations, but yet look for progress. So these are some of the actual things that we're going to be doing to implement activities. As Ramona mentioned, we're currently implementing purposeful rounding in Saskatchewan care homes. And so during the next fiscal year coming up, we expect to do another third of the care homes. So we're doing third this year, another third next year, and then we'll probably do the final third the following year. We do a resident and family satisfaction survey, which has recently been implemented as an annual event. And so although we're not certain about the format this is going to take this year, we're certainly going to move ahead with having some type of annual survey. We're currently developing some training resources that really center around some DVDs that will chunk out the policy manual into manageable chunks so staff can watch a 1-hour DVD, have a bit of a discussion, and work that into their day so that eventually all staff in care homes are trained. And then we will have our public reporting actually online and easily available to everybody in Saskatchewan so that they can look at how a particular care home is rated on various components related to the policies. And then over the whole fiscal year next year, we do plan on looking at how we can develop a overall long-term care strategy to better provide quality care over the long term to residents. So then following that next fiscal year, we're going to be gearing up to actually move into the following year, which will focus more on community-based initiatives. So during this next fiscal year is like a planning period where we can be better ready to actually jump in with new initiatives the following year that will provide better support to seniors in the community so they can remain in their homes longer and age in place, which is what they have told us they want to do. So that's the last slide. We're going to move on to the next one. Yeah. Okay, thanks for your attention.
Okay, our IT people are telling me that we have Kathy lined up to be able to, she's the Director of Mental Health and Addiction Services for Saskatchewan, and she's joining us from Moose Jaw.
Good morning, everyone. Thanks for that introduction. Actually, I'm calling in from Regina, so I just wanted to clarify that. And yes, I'm the Provincial Director for Mental Health and Addictions. And many thanks to the organizers of this opportunity to be able to speak about the Mental Health and Addictions Action Plan and some of our work in this area that links to your topic this morning. I'm certainly sorry that I'm not able to be there in person. I have lots of colleagues who are in the room, and in particular, Mr. Lawrence Sear is in attendance and will be able to respond to any questions about mental health and addictions as you have further conversations. Mental health and addictions issues affect 1 in every 5 Saskatchewan residents. Indirectly, they affect many more as parents, family members, and service providers feel the impact of mental health and addictions issues. In 2013, Health Minister Duncan appointed Dr. Fern Stockdale-Winder as a commissioner to develop a 10-year interministerial action plan to address the complex and often connected issues of mental health and addictions. On December 1st, 2014, the commissioner submitted her report. And then on behalf of all of government, Minister Duncan endorsed the report as a guide to how we can all improve our response to people with mental health and addictions issues. The action plan is a culmination of extensive public consultation across the province with a particular focus on people with lived experiences of mental health and addictions issues, their family members, service providers, concerned citizens. It complements the patient-first work that was completed earlier and ensures that the voice of the customer will guide our next steps. The recommendations in the Mental Health and Addiction Action Plan provide a guide to approach these issues with new ways of thinking and working together. I'll point out for today's purpose that one of the identified system goals is to enhance access and capacity and support recovery in the community. So it's focused very much on the role of primary health care providers, which is really our topic here today. Under this system goal, it's broken down further into 2 recommendations. 3.1, to support the work of primary health care providers through team approaches that include ready access to mental health and addictions counselors and consultant psychiatry. And 3.2, to make screening and brief intervention tools accessible combined with effective clinical pathways and referral networks. Addressing mental health and addictions issues across so many service sectors is complex and takes the efforts of many ministries and organizations collaborating together. We are already making improvements in many areas, and the action plan affirms that direction. The report recognizes collaboration that is already underway and notes that the success of many of the recommendations is dependent on our ability to work together better. For example, a number of regional health authorities are providing additional after-hours care in places like primary care clinics or urgent care centers, enhancing after-hours and supports for people with mental health and addictions crises. better supporting the police and those that they serve in the community through solutions such as police and crisis teams, commonly known as PAC teams. These responses have the potential to help reduce the number of people who present at the emergency department. Another example is the innovative partnership between the Saskatoon Health Region and the Whitecap Dakota First Nation, where we provide integrated primary health services, which include an element of mental health and addictions as part of their health center. More importantly, these are examples of the focus on the interministerial work and how we are all better when we work together. A number of recommendations in the action plan are already being addressed. The redevelopment of Saskatchewan Hospital North Battleford, commonly known as SHNB, although not specifically mentioned in the action plan, is underway and will start this fall. This 100-year-old building will be replaced with a 188-bed psychiatric rehabilitation hospital and a 96-room correctional facility for persons with mental health and addictions issues who are presently incarcerated. As a provincial resource, it will better meet the needs of mental health patients who require an inpatient rehabilitation in a modern environment. A provincial project to reduce emergency wait times has provided resources to a health and police team in Saskatoon and is currently being expanded to Regina. This important collaboration between police and regional health authorities supports people with mental health and addictions emergencies and will not only improve responses in ERs, but will improve the care for people with mental health and addictions issues. An important response to addressing growing numbers of people whose mental health challenge is a diagnosis of dementia is the development of 2 dementia units, one in Regina and one in Saskatoon. The Ministry of Health is also using the hotspotting model into connecting to care projects, which you've heard a bit about this morning already. And these are designed to offer a better health system service to some of the highest users. These projects in Regina and Saskatoon are improving our response to persons with mental health and addictions issues that are heavy and often inappropriate users of services. The Ministry of Health has trained staff in every regional health authority to provide mental health first aid to partnering ministries and agencies. This course, which operates under the leadership of the Mental Health Commission of Canada, aims to provide a better understanding of mental health and addictions issues, to reduce stigma and increase awareness. It focuses on signs and symptoms of addictions and several types of the more common mental health conditions, such as mood disorders, anxiety disorders, and psychotic disorders. Over 100,000 people in Canada have been trained, and we are pleased to add to this complement here in Saskatchewan. Since January, the course has been offered by the regional health authorities 18 times, reaching more than 300 people, including educators, police, social service workers, corrections staff, primary health care staff, and many more. You've likely all heard about the health system's work to reduce wait times in many areas. Recognizing the burden to individuals and families in the mental health and addictions area, we've been working in collaboration with regional health authorities to reduce the wait time to access outpatient mental health and addiction services. I'm pleased to tell you that this year further work in this area has been set as a priority for the whole health system. We recognize that this is a stretch goal for us, but there are significant demands on our service providers, and are pleased with both the commitment of the system to tackle this work and the progress that we've made to date. While we recognize that preventing suicides is never in the hands of only one part of the health system or one ministry, the tragedy of any completed suicide has prompted the Ministry of Health and the regional health authorities to develop protocols and policies to guide the practice of mental health and addictions, working with those who are at risk of suicide. As I mentioned, the report contains 16 recommendations that fall in 7 categories and contain many sub-recommendations which add up to a total of 46 recommendations. The 7 themes are enhancing access and capacity and support recovery in the community, focus on prevention and early intervention, create person and family-centered and coordinated services, respond to diversities, partner with First Nations and Métis people, reduce stigma and increase awareness, and finally, transform the system and sustain the changes. The recommendations were not prioritized in the report, but Dr. Stockdale-Winder has noted and continues to communicate that supportive housing is a pressing need, as well as enhancing system access and capacity and services for children and youth. Together with partner ministries, including social services, education, justice, corrections and policing, we have begun laying the groundwork for the implementation of these recommendations. Since the release of the report, the Ministry of Health has been focused on leading the development of an interministerial implementation plan. It's a 10-year action plan, and it's important that we spend some time ensuring that we understand what comes first, what comes next, and what the best next steps are. We have asked each ministry to review the recommendations against their current strategic direction and to confirm that this is aligned. Together we'll assess the priorities and recommend sequencing that will build upon the good work that's already underway. Although many recommendations ask for an all-of-government approach, other recommendations speak to work that needs to be done in specific systems. Along with our partners from other ministries, we will confirm lead ministries. Where possible, we want to continue building upon work that we have underway already. By the end of this fiscal year, we want to have an implementation plan that describes the goals for the short term, the mid-term, and the longer term. Recently, the Ministry of Health has been working on the early detection of mental health and substance abuse in primary health care. We are working with Prairie North, Regina Capel, Cypress, and Five Hills health regions on implementing a two-stage screening and assessment for brief treatment and referral pathways in primary health care. We've used the expertise of Dr. David Brown, a researcher with considerable experience and background in this area. The Ministry of Health plans to continue to work with the health system on expanding early detection and mental health and substance abuse and misuse in primary health care, and on evaluating the sites where the screening and assessments were introduced. I look forward to hearing more about your discussions throughout the day, and about the discussions that will go on this afternoon as we have an opportunity to dialogue further about the directions, and in particular in integrating with primary health care. Thank you.
Good. And this afternoon for the table session, Janice Cahoon, who's Kathy's executive director, will be leading the table on mental health. So we will be able to ask questions related to the presentation at that time. Okay, the final section of the government presentation is from Graham Fast, who's here and will be speaking to ED wait times and the patient flow portion of the government's priorities. Thanks, Graham.
Okay, good morning, everybody. Appreciate the opportunity to be here. My name is Graham Fast. I'm at the Health Quality Council. I'm the lead for the ED Waits and Patient Flow Initiative. It's we're at Health Quality Council, but we have a very close relationship with the Ministry of Health, to the Deputy Minister's Office through the Strategic Priorities Branch. I'd also like to just quickly introduce Kelsey Kevinson, who's one of our project policy analysts, who will be here with me this afternoon to help with the facilitated discussion. So the Emergency Department Wait Time Initiative, I could spend an hour here. There's no way I'm going to be able to do justice to the work, the complexity of the issue, and the solutions in 15 minutes. I realized that as I was looking at my presentation this morning, I've got way too many slides, so I'm going to skim over a lot of stuff this morning, but I know that there'll be an opportunity for an interactive session this afternoon where I can hopefully answer some more detailed questions. We are a patient-first initiative. We're the next of the patient-first initiatives after the SAS surgical initiative, so we're following on the heels there, operationalized through a provincial Kaizen operational team at the Health Quality Council. This work stems from the patient-first review, where one of the 8 negative experiences that it was identified by patients and families was the experience within the emergency department, and specifically the long wait intervals that people were experiencing in the department. The root causes, we often refer to the wait time in the emergency department as the canary in the coal mine. You've probably heard that term before. It's a place where the issues become highly visible to patients and families, but really the issues and the solutions are outside of the emergency department. So we are talking about issues impacting like bottlenecks and impacting patient flow upstream and downstream from the emergency department. So when we do sort of a detailed root cause analysis through literature review and environmental scanning, meeting with stakeholders across the province, the issues are, first of all, the high volume of patients that are coming in the emergency department. That is due to lack of real or perceived options for care in the community. So by default, lots of people use the emergency department for their primary care needs. Health Quality Council did a survey in 2012 of patients coming into the emergency department, and 50% of the patients coming in said, we don't want to be here, but we don't perceive we have any other options. And 30% of the patients coming in said that they were actually told to go to the emergency department for an intervention or for some service. So it's a huge amount of patients coming in that probably should be and would be better cared for in a safer environment outside of the emergency department. Secondly, don't get me wrong, there's lots of operational inefficiencies within our existing emergency departments that could improve their flow processes to improve our wait times and access. Third root cause really is our high occupancy rates within acute care. So literature shows anytime your acute care units, your medical surgical units are over about 85 to 90% occupancy, that's when the backlog starts to occur into the emergency department. And as an administrator in our health system, I can't remember a time where we operate under 100% capacity in most of our tertiary centers. So what happens is our admitted patients obviously can't access an inpatient bed in a timely manner. They get stacked, for lack of a better word, in the emergency department, and that uses up the space within the emergency department, so you have less stretchers, beds, spaces for the emergency room physicians and nurses to actually see patients, and that leads to the wait time in the emergency department. So the fourth, and this is directly related to our overcapacity, our occupancy rates. High occupancy rates is the ALC days. And I'm going to suggest that this is probably the biggest factor that's facing the system right now from a patient flow perspective and impacting emergency department wait times. So we have this enormous population of alternate level of care patients in acute care. And by definition, they no longer require the intensity of services of acute care, but there's no place to safely discharge them to. So that really boils down to the lack of appropriate community resources to care for complex, frail elderly and other complex patients in the community. So they remain in hospital, and that causes the overcapacity, the overcrowding. So as you can see, the issue, we call it the emergency department wait time. There's political reasons for that, obviously. There's also, that's where it's highly visible to the public. But the issues are far more complex in the emergency department and outside. We've also added in a couple different root causes, and although they may not be directly related to patient flow, they are issues that our initiative are facing. And one is the lack of evidence-based decision-making tools. So we oftentimes, as a health system, we act on gestalt, we act on best guess, and we implement strategies, but we haven't really got a tool that we can use to perhaps do a virtual pilot per se, and I'll come to that in a minute when I talk about our strategies. We have issues with quality and real-time data access. The emergency department data that we get from CIHCI through the NACRS database is 3 months at best old, so that's difficult for our administrators to make decisions on. And because of varying workflow processes within emergency and within acute care, the data that we get is not comparable sometimes between hospitals within the same region, but definitely interregionally it's not comparable. So it makes it really, again, very difficult for decision makers to act upon. So we have strategies to address that, which I'll come to. So the metrics that we're staying focused on right now as an initiative is that we're focusing on the time waiting for an inpatient bed. So that is our HOSHN target. I assume people are familiar with the term HOSHN, but that just means it's our highest level of strategic priority in the province. It's our must-do, can't fail for this year. So time waiting for an inpatient bed is the interval between the decision to admit to the time they get into an appropriate bed in acute care. And we're also focusing on length of stay. So one thing you'll see is that we haven't focused on is the time to see a physician in the department, which is kind of what most people sort of think of as their wait time, right, in an emergency department. The reason we no longer focus on that is that accuracy issue that I was talking about. We don't have accurate data there, so and it's certainly not comparable across regions. So we've decided to do some work on cleaning up the data before refocusing on it. Our balancing measures we look at are our 7th-day ED revisit rate and our 30 to 60-day acute care readmission rates. We can give copies of this to people. This is just a driver diagram showing the metrics. The primary outcomes that we're focusing are wait intervals, so time to see a physician, and the time waiting for an inpatient bed in the emergency department. But if you look at the drivers behind that, as I said before, it's really hospital occupancy, it's ED volumes, and it's length of stay. So if you break it down, there are multiple secondary drivers. We use this visual just so that regions, as they're wanting to implement strategies or research the issue, they can see the line of sight from strategies that are happening downstream to the impact that it has on the emergency department wait intervals. So maybe what I can do is just quickly back up. The initiative's primary outcome is to create a zero-wait environment in the emergency departments. And originally we were thinking 2017 as being the timeline horizon for that. I think it's clear from our studying of the issue that it's far too complex. The system capacity for change is going to be such that we can't achieve that by 2017. There's lots of debate whether or not it's ever achievable too. So the initiative right now is trying to look at what is more appropriate for an outcome and for a long-term outcome and the timeline that we'll achieve it in. So that's sort of under review. That's why I haven't sort of stated that in the presentation. So for 2016-17, these are some of the strategies that we're going to be focusing on. I've got a few more detailed slides on each of those I'll go through. I put up this visual because when we think of the scope of this initiative, we talk about the entire continuum of care. So for purposes of communication and for organization, we talk about 4 phases of the value stream, if you will. So we have pre-hospital primary care services as phase 1, the emergency department care, phase 2, the acute care process, phase 3, and then the community-based downstream interventions as phase 4. So I know that this probably is more circle than it is a linear, but it's, again, for communication, we use this tool. The moving parts are obviously all interactive, as you're going to see. One impacts the others in terms of our strategies. I'm going to start off with our ALC strategy, because as I said, I believe this is the most important thing facing us, is the patients that are in acute care that no longer require that level or intensity of the resources that they're getting. The problem is we don't know how many and who they are and exactly where they are, because we don't have good data on our ALC population. So traditionally, we've, as a system, have only captured ALC as patients that are waiting for long-term care, but there's a huge amount of patients that are very complex, that do not qualify for long-term care that still are in our acute care beds. So this year's work has really been focused on creating a standardized data collection process and form, so that at least across the province, each region is collecting the data in a standardized way. That will give our strategy next year an ability to analyze that data, and that will, I think, inform the services that we need to put in place in the community to safely transfer their care out of acute care into a more safe setting. So So again, I'll just kind of flip through these. The community services strategy. This is what you heard from the seniors presentation. One thing we're realizing as the outcomes of seniors, primary health care, ED Waits are getting together is there's so much overlap, so much synergy in the work that we're doing, opportunities to leverage each other's work. This is a really good example, is that the year 2 seniors community-based services strategy, well, the information that informs that work in terms of what services need to be put in place for seniors in the community will come out of our ALC strategy for ED Waits and patient flow. So as we start to get a more robust database, understand the patient profile, that will inform the work that seniors needs to do in the community in year 2 of their strategy. And obviously putting in the primary health care services in place as well. So you can see that there's lots of different moving parts, but lots of overlap that we'll have to account for as we go into implementation. We need to, one of the strategies will be to continue to improve upon the quality and timeliness of the data that we do have. Within the ED, there's lots of process improvement work that is going on and will continue to go on over the next year across the province. There's a few different strategies that are being contemplated. One there, for example, is a pilot of a geriatric nurse practitioner role, and perhaps aligning with some of the work that's happening in appropriateness as well within the emergency department. The care coordination strategy, so this is really refers to strategies within the acute care part of our system. This year what we've done is we've developed a toolkit for the implementation of interdisciplinary rounds. Having bedside physician-attended interdisciplinary rounds is best practice. Our goal is to get to at least 50% of medical surgical units in the province having bedside physician-attended interdisciplinary rounds this year. It's a stretch target, we won't get there, but for next year we really have to pull out a solid implementation strategy about how we're going to achieve that across the province. The rural and remote bridging strategy, this really is related to transfers of care, safe transfers of care through what's not maybe an appropriate word in healthcare, but repatriation. It's about inter and intra-regional transfers of care. So as patients come into tertiary care for their care and their needs are met, how do we safely transfer them back to the communities, either their home hospital or their home region? And right now there's a lack of standard work across the province. There's a lack of standard process. So the work from this year has been really putting together work standards and flow processes that all regions can incorporate. Next year will be how do we implement those strategies. Health systems modeling, this is some exciting work that we're doing at Health Quality Council, and this is a computer-based dynamic modeling that we can start to use to do, what I think is, I heard a good term this morning called virtual pilot. We can actually start to run scenarios to help us help inform us where to make strategic investments in the system. For example, we know that we probably can't invest across the entire continuum of care because of finite resources. So where are we going to get the biggest impact for patients and families? Is it going to be with an investment upstream in primary care? Is it going to be in the acute care? Will it be in the emergency department, or will it be downstream in resources that help facilitate discharge? So again, this is a tool that you can learn more about this afternoon if interested. And as you also heard this morning from seniors, is that we have finite resources when it comes to geriatric core competencies in the province. One of the strategies for next year is how can we best utilize that finite resource that we have, but also how can we spread that knowledge base that we have at our Saskatoon team across the province. Personal care home strategy, just again, we know that this is an untapped potential within the community for capacity, but we also know that there's some quality of care issues. So for this year, we're just doing a bit of an environmental scan around best practice nationally and internationally. We will be, over the next year, doing some more detailed value stream mapping and PQA analysis. Another piece of work contemplated for next year is standardizing provincial overcapacity protocols. And I know I'm running over time here, and I'm standing between you and lunch, so I'll go. But briefly, right now, there's no standard language or framework that we use in the province around overcapacity. So a Code Burgundy in PA means something very different than an overcapacity alert in Saskatoon. And the triggers are different, the escalation protocols are different, and it leads to a bit of what I would say is a culture of mistrust. So if I pick up the phone and say, I'm transferring a patient back to you, and the receiving region says, well, we're way too busy. We've got too many patients in our hallways. Well, we've got more patients in our hallways. So there's no standard language or framework, and I think that's something that our team would like to address for next year. The challenges ahead is that our proposed target changes haven't been landed on yet, so we need to work with government around that. Some of the interventions that we're contemplating are expensive, and the limited budget is an ongoing challenge for us. Awareness of the initiative, and I think that's a real challenge that we've had, is I think that at the senior leadership level, maybe the operational leadership level across the province, there's awareness of the initiative, but I think lower than that, we're not getting to the point of care, we're probably not getting to the managers, and that's leading to barriers when it comes to implementing some of the initiatives. I think there's a real opportunity ahead, though, and I know at the ministry we're having lots of conversations now about how do we align our work for seniors, primary health care, ED weights, and patient flow. There's so much overlap, so much synergy, so much opportunity there, and in an environment of finite resources and human resources, it's incumbent upon us to work together. So that's an opportunity. That's it. Thank you.